Okay, we're going to call the meeting to order. Please rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Welcome, everybody. Dee, would you please take the roll?
Director Wallace.
Present.
Director Stewart.
Present.
Director Eapen.
Present.
Director Nicholson.
Present.
Director Danielson.
All right. Nancy, please.
It's my pleasure to introduce our speaker this evening for our education session. Dr. Alan Spira is from our Department of Emergency Medicine. He's been a member of the Washington Hospital Emergency Department medical staff since 2014. He completed his undergraduate education at UCLA, his residency at USC. He's also trained in tropical medicine and acupuncture. He is a U.S. Navy captain and serves as battalion medical officer for the 2nd Battalion, 23rd Marine Regiment. He is an active member of both the Ethics Committee and the Emergency Operations Committee. This year, he actively participated in the planning and implementation of the statewide disaster drill. Dr. Spira regularly presents updates to the emergency nursing staff regarding infectious disease and other interesting cases. This unique combination of emergency medicine and military experience certainly qualifies him to speak about mass casualty incidents and triage. With that, I'd like to welcome Dr. Alan Spira, and it would just add that given what we have seen on television of what has gone on in Southern California in the last 24 hours, this talk could not be more timely.
Thank you. Good evening, everyone. Can you hear me well? Okay, great. So again, I'm Alan Spira from the Department of Emergency Medicine. We will talk about triage and mass casualty incidents. A mass casualty incident is just that. It's lots of patients all at once. This definition is a bit verbose and bloated, but you could think of it as the oh my God moment, when what you are getting is too much for you to handle in the time and restrictions upon resources and staff, and your medical resources are strained to the limit. There are many different kinds of mass casualty incidents. We're most familiar with earthquakes, natural disasters, fires, as we have just seen, both in the north and in the south. There are also the risk of terrorist attacks. We've seen that as a mass casualty incident cause. In addition, there are civil disturbances and hazmat issues. You can think of hazmats as though a great example would be a train derailing and releasing toxic chemicals. I'd like to point out the happy coincidence of the path of the Hayward Fault and where we're sitting right now. This is likely to blow before the San Andreas Fault, and with the greater population density in the East Bay, is likely to be a far greater catastrophe than that of the San Andreas blowing. Different kinds of disasters have different kinds of consequences. I'd like to point out with earthquakes specifically, you not only have many casualties, but they're very complex. In addition, our infrastructure is likely to be damaged, if not crippled. Oh. The internet tried to take me over. Okay, are we back? We are back. Good. I'd like to tell you that I worked at Northridge Hospital the day of that quake in '94. And that was quite a mass casualty incident. There were 2 cases going on in the OR during the quake. We lost the ORs, we lost our 2 CT scanners, we lost the ICU and the NICU. The power was brought back quite quickly. However, the overhead lights were all busted, so it was hard to see, even despite having power. Our waterworks were completely shattered, and Anheuser-Busch, the beer factory, which is up the road, sent us water to keep us going. And yes, the water was in beer cans, but it was water. So I'd like to point out that in a mass casualty situation, you don't know what to expect, and you can't predict what's going to happen to you. Now, the next, this seems to have changed since that internet abduction of my computer. Okay, I can do it manually. No problem. This chart demonstrates the demands upon the system versus time. With a single time entity event, you'll get approximately 50% of your patients in the first hour and up to 75% in the first 2 hours. During this surge, chaos and organizational breakdown will occur in the absence of effective disaster planning and in the absence of a rapid initiation of a strong command and control structure. As few as 5 critical patients per hour will overwhelm most urban trauma centers. And the percent of patients getting quality care will drop as the number of patients per hour rises. That's why this graph is so important to remember, right here. When you have a mass casualty incident, many things are occurring all at once, and you have what I call the fog of war. It is difficult to understand what's going on, to capture the situation, understand the complexity or the size and scope of what's going on, figuring out who's in command at the moment and the command shifting, controlling the scene and its environment, the inevitable communication failures, the inevitable logistical failures, and interference from people who want to help and from people who don't have quite the best benign interests at heart. All of these influence triage. And triage is the key to dealing with the patients in a mass casualty incident. Triage comes from the French word trier, which means to sort. It's the process of determining the priorities of patients in their treatments and based on the severity of their conditions. Modern day triage can be attributed to the French surgeon Baron Dominique Jeanneret, who was in Napoleon's army. He elucidated during the Napoleonic Wars that there were essentially 3 categories of patients. Those that were going to live no matter what he did, those who would die no matter what he did, and those who had a chance at survival if he made some sort of rapid intervention. And that was the birth of modern day triage. This is what we do in standard everyday practice. Someone is sick or injured, they come straight to the hospital, or they call EMS, and they come here, we throw everything at them. The sicker one is, the higher their priority. And that's fine when the numbers are small and we can absorb it, but it's not good when there's a large number of patients in a compressed period of time, which overwhelms the system. You could have 5 patients from a motor vehicle accident, which would be easily absorbed at a major trauma center, but could actually initiate a mass casualty response in a small community hospital. In mass casualty triage, you turn everything up on its head. The priorities are completely reversed. You want to do the most good for the most people, and the reversing this priority is what gives many people ethical heartburn who have not thought this through or have not lived through a real disaster. Not everyone will get treatment. Things like CPR aren't even done. The goal of triage is to prioritize the attention on those who can be saved with the highest priority and probability. This was originally devised by the military, and it is equally applicable in civilian practice. When you have an incident, you do triage at the scene. You have to sort out who are the most serious, salvageable patients. Then they're taken to a casualty collection point where they are re-triaged. From there, they go to the hospital where they are triaged again and again. The status of a patient is in constant flux. You have to reassess them because their status is not something you can predict or rely upon. In fact, sometimes the triage process is so fast, in the field you may only have 10 seconds per patient if there are a large number of casualties. Triage essentially has to be a very simple procedure that's rapid, reliable, and reproducible. There are 4 categories for simplicity in triage. Immediate, which is categorized as red. Delayed or urgent, which is yellow. Minor or minimal, green. And expectant, which is black. There's a little difference between the names depending on which system is applied, but essentially it is the same. The highest level is the immediate category, right here. These are the patients who can be saved in the most critical situation. These patients have only seconds to minutes for an intervention. Examples include airway obstruction, massive hemorrhage, which is usually of the extremities, unstable chest or abdominal wounds, pneumothoraces, sucking chest wounds, complicated burns, and incomplete amputations. The second category, the delayed/urgent, is a little harder to peg patients into. They have significant injuries, but they have hours, perhaps even days, before a significant intervention has to be done in order to save them. And you have examples of large bone fractures, uncomplicated major burns, head and spinal injuries, stable chest and belly injuries, vascular injuries with controlled bleeding, and most eye injuries. The minor category are those who have the least serious injuries. And they're indeed quite minor. They're called the walking wounded. However, they can be the most problematic. They can be interruptive, they can be noisy. In a disaster situation, the patients you worry about the most are the ones not making any noise. The ones who are making the most noise are probably not in a sorry state. The ones who are quiet are the ones that should scare us. And this associated with this level are the worried well. There's always an influx of the worried well when you have a mass casualty event, where you have people who think something is wrong or worried that maybe something might become wrong, but they're perfectly fine, and yet they strain the system. They do divert time and resources from our response. The fourth category, the expectant category, are those who are tragically have no chance at survival, none. And these victims can be denied care in the interest of applying limited resources to those who are salvageable. Usually in this scenario, you just have a nurse or a doctor with narcotics providing comfort to the patient and nothing else. And these patients are often put out of sight because they're so distressing to other patients or to staff. There are many algorithms to help you in a mass casualty situation in doing triage. The best one, my favorite, is the START adult triage, simple triage and rapid treatment. This was devised at Hoag Hospital in Newport Beach in 1983, and it's used nationwide, in many countries, in fact. And let me walk you through it, and you'll see how simple and how applicable it is. You come upon a disaster scene. You have a patient who's able to walk. That person immediately goes into the minor category. That's good news. But let's say they are not breathing. They're not walking, they're not breathing. You position their airway and you open it. If they're still not breathing, well, that puts them in the expectant category. You don't spend more time trying to salvage them. Not when you have many more casualties and when you don't know how many more are still coming. Now, you check if they have spontaneous breathing, and if they do develop it, they become an immediate category. Then, if their respiratory rate is greater than 30, they stay immediate. But if the respiratory rate is less than 30, you check their perfusion. If they don't have a radial pulse anymore, or their capillary refill is diminished, they become immediate. But if they pass that level, you then check the mental status. If they're obeying commands, they fall into the large catch basin of delayed, and if they don't, they're immediate. So you can see this can be applied in seconds. If you know the system, if you're interested and willing to apply it, this is a great tool. The triage tag here is attached to patients as they flow up the triage stream from the point of injury to the hospital. This is a legal document. This is part of the medical record. Unfortunately, it has problems. People don't use them properly. They get lost, they get wet, they get bloody. I'm looking forward to the day when we have RFID tags and we can track our patients in real time, but we're not quite there yet, hopefully soon. That raises the question of who does triage. And as far as I'm concerned, it doesn't matter. What matters is the person knows how to do triage and is willing to apply the principles of triage. That's the best person suited to do the triage. There are many ethical issues involved with mass casualty triage. You have to view the emergency as a whole and don't judge individuals. That's an important foundation. Everyone has equal access to the health care, but not everyone will get equal care. And that's difficult for many people to absorb. Some patients will simply not get treated. You should also be aware that triage officers who don't understand the ethical bases of their decisions will be indecisive and suffer emotionally. Furthermore, if healthcare workers managing these patients or the public doesn't understand the ethical reasoning behind these decisions, they may not accept those decisions, and that can come back to haunt us. So it's important to educate people as quickly as possible as to how things are done, ideally in advance, but many people don't want to hear this in advance, but we need to be aware of this. The basic ethical principle in mass casualty incident triage is to do the best for the most without any favoritism. In our own lifetimes, there have been numerous major mass casualty incidents. Starting back at Loma Prieta, we can go to the LA riots, the LA County Hospital shooting, Northridge earthquake, Kobe earthquake, the Tokyo subway attack, the New York City 9/11 attack, the Indian Ocean tsunami, Hurricane Katrina, Haiti quake, Fukushima quake, Superstorm Sandy, the Boston Marathon bombing, the San Bernardino shooting, the Orlando shooting, the Bronx Lebanon shooting, and Las Vegas. Let's analyze a few of these and see what we can learn and how we can apply it here to Washington Hospital. Let me take you back just 3 months. This couldn't be fresher, I think. Stephen Paddock on the 32nd floor of the Mandalay Bay Hotel opened fire on a bunch of concert goers in Las Vegas. He murdered 58 people and wounded 546. Greater than 60% of these were gunshot wounds. The rest were shrapnel or orthopedic injuries from people either trying to escape or being trampled. 627 patients were seen at 11 hospitals, the majority at just 2, at UMC and at Sunrise Medical Center. The University Medical Center is the only level 1 trauma center in the state of Nevada, rather. And they had some great difficulties. They managed well, but they still had great difficulties. They particularly ran out of supplies quickly, including intravenous fluids, chest tubes, urinals, and blankets. They had a great trouble with space, being able to accommodate the incoming wounded. And they also had issues with reunification, which is a theme that we will see over and over. In contrast, Sunrise Medical Center, which is a level 2 trauma center, it's a community hospital with 701 beds, did very well, I have to say. They were lucky in a sense. Luck, you will see, is also another factor that plays in mass casualty incidents. There was a police officer in the emergency department and his radio went off informing them that there was a disaster coming in because of the shooting. They cleared the ORs, they called in additional staff. They, having a pod system in their emergency department, were able to break down each pod according to the 4 categories that I described earlier. So you had an immediate here, you had a delayed here, et cetera, et cetera. And it made life simple and efficient. They found that patients were being brought in by EMS and police, sometimes as many as 4 in a police car just being dropped off. Now, there were a couple problems that they faced, like UMC. One was the Pyxis system. The nurses could not get the drugs out fast enough. Pharmacy wound up bringing all the critical care drugs from their main room and bringing it to the ED. The second issue, like UMC had, was running out of supplies, but they were very innovative. What they did in cases such as when the chest tubes ran out is they went to endotracheal tubes. When they ran out of ventilators, they took Y tubing and put 2 patients per 1 ventilator. When they ran out of cardiac monitors, they resorted to the old-fashioned visual monitoring. They restricted the amount of testing they did. In fact, only CTs were done, and CTs were only done when indicated when someone had an isolated gunshot wound to the head. Those patients were intubated, had a CT, and were immediately moved out of the ER straight to the ICU to await the neurosurgeon's arrival. They did not keep patients in the ED, and they got patients into the OR as quickly as possible. This hospital saw 215 gunshot victims. They discharged 137. Their surgeons were heroic. In the first 6 hours, they did 28 damage control surgeries. In 24 hours, they did 67 surgeries. That's most impressive, and my hat is off to them. And here is the aftermath of the shooting. Now I'd like to take you cross country. I want to go to New York City. A year earlier at the Bronx Lebanon Hospital, there was a disgruntled doctor, someone who had been fired for sexual harassment. He came back into the hospital hiding a gun. He went up to the 16th floor of the hospital and he opened fire specifically targeting doctors and nurses. He then put fuel on the nursing station, lit fire, and the ensuing smoke and chaos went up to the 17th floor and repeated his dastardly deeds. He wound up murdering Dr. Tracy Tam. He wounded 3 doctors, 2 medical students, and 1 patient. Now, one of the important consequences is that New York Police Department locked down the entire facility completely. No one in, no one out. They didn't know if there were other shooters. They didn't know what the risk was to other personnel. This was SOP, and I understand it, but the downside was no one was allowed to go up to the upper floors to render medical aid to the wounded and dying. But that was the policy. We have to understand that safety is a major concern in a mass casualty incident, and we have to balance with that. Now we're going to come back to California. A year earlier in San Bernardino, 2 terrorists murdered 14 dead and wounded 22 others. The majority were seen at just 2 hospitals, Loma Linda University Medical Center and Arrowhead Regional Medical Center. Let's analyze these because there's much to learn here. Loma Linda was 3 miles from the incident. It's a major hospital, 714 beds. It's a level 1 trauma center, and they see 70,000 patients per year. Interestingly, in this scenario, what happened is they got a call from the firefighter directly at the scene. They did not get activated by the ReadyNet as they should have. Based upon this one call, the charge nurse and the nursing soup decided to activate their mass casualty response. The ED was initially packed. They cleared out the ED as fast as they could. There were some patients they could not remove, and they couldn't empty everyone out of triage. But they did what they could. They brought in the disaster carts from their reservoir and put it out into the triage area. They assigned the staff roles. They gave phones to key personnel. They activated the trauma surgeons, and they generated blank charts and labels quickly for the expected patients, even though they didn't know how many patients they were getting. All traffic was diverted away from the hospital. Only EMS and police were allowed, and they also established entry control points at each door for safety. What's really remarkable, all this took place in less than 20 minutes. That's phenomenal. That's good practice. That's great training there. Now, their response, they had 3 attendings on duty in the emergency department that day, but these guys were lucky. There was a conference on the hospital grounds of 40 extra doctors. Couldn't ask for a greater blessing. Now, they divided up their tables, resuscitation beds, so that they had 11 of them. They put 1 attending, 1 resident, 3 nurses, 1 emergency tech, and 1 respiratory therapist per bed. The chief of trauma and 8 additional surgeons were made available immediately. The directors of lab, imaging, and pharmacy came to the ED to help run things. They didn't send anyone else, they came themselves. That was very good. The additional staff were called in from their backup call list. The blood bank committed 2 runners and 60 units of blood, cryoprecipitate, fresh frozen plasma, and also platelets. During this period, there were still 15 patients who had to be seen. So they committed a doctor and nurse to take care of those patients. And these weren't trivial patients. They had a hot stroke, they had an acute respiratory distress that required intubation, and they had an acute arterial occlusion of an extremity. So even as the disaster response was going on, they had critical care patients to take care of. Here's the timeline. At 11:44, the first patient came in with a gunshot wound to the chest, initially stable, but quickly crumped and required blood before going to the OR. 4 minutes later, the second patient came in with a chest laceration and multiple wounds to his face, arms, and legs from shrapnel, wound up going to the operating room. 2 minutes later, a third patient came in unstable with a gunshot wound to the chest, got chest tubes, and went to the operating room. So 3 ORs are already filled within, 6 minutes. 5 minutes later, a multiple gunshot wound victim came in, and he needed to go to the OR after getting blood and tranexamic acid. A couple minutes later, a 5th patient came in but didn't require the OR. And at this time already, within minutes, there were TV news helicopters already circling over the ambulance bay, photographing what's going on. The nurses came out with bed sheets, and from the ambulances, they walked the patients and hid the patients from the prying eye of the TV news crew. Good for them. Now, their after-action report, which is the same thing as a lessons learned, concluded that they did really good seamless setup, and I agree. Very impressive, very professional. They minimized their ED treatment procedures. They did them as many as possible in the operating room to free up the ER. You want to empty the ER. You want to empty the hospital if possible when you have a mass casualty incident. You don't know how many people will come in. You need to be prepared for the worst. In addition, they divided their teams into triage, disaster, and existing patients, and it worked great. Curiously, The hospital IT was overwhelmed. Everyone was trying to live stream the newscasts. So the hospital said, no, only the ER and only the Emergency Operations Center had the right to the internet. And that helped a lot. It also kept people from being distracted on the floors. Safety turned out to be a concern because there was a bomb threat. And as a result, the hospital had to be locked down. The bomb threat was a false call, but nonetheless, what that does is impact the time and ability to take care of patients. They also noted that they had a big problem in establishing a need for a reunification center for family. But overall, they did very well. Now, from Loma Linda to Arrowhead Regional Medical Center. They were 5 miles from the incident. They're a level 2 trauma center, but big, 456 beds. They see 116,000 patients a year. They're busy. In their case, they got a call from the police department 7 minutes before the ReadyNet activated. When you're preparing for a mass casualty, 7 minutes is a lifetime. Unfortunately, the ReadyNet failed twice now. They had also 3 ED attendings on duty. One was a SWAT member, and he elected to go see the action, and he left his post, which I don't agree with. But they were also lucky in that they had a conference on the grounds with additional doctors who they could pull in. And they called in additional doctors and nurses from their emergency call list. Now, their response, they had 8 trauma beds reserved, and they took 4 regular beds and converted them into trauma beds within minutes. They had enough staff that they could take 1 attending, 2 residents, 2 nurses, and 1 tech per bed. They had 4 anesthesiologists on standby. Every respiratory therapist and every free ventilator in the hospital was brought to the ED instantly, without hesitation. They dedicated x-rays and the CTs just for the ED's use. What was very nice in this case, the hospitalists, both adult and pediatric, helped dispo the patients. They came to the ED and they moved the patients, either admitted them right away or discharged them right away, which helped relieve some of the strain on the emergency department. Just like at Loma Linda, they had to have a separate ED crew for the routine, quote, routine patients who were sick. In this case, at Arrowhead, more than 70 additional doctors and nurses showed up who were unfortunately not needed. They were in the way. They didn't have the skill set that was needed, even though they had the good intention. So they wound up being assigned to a room and being told, please wait, we'll call you when we need you. And most of them wound up going home without being involved. Their timeline was very similar to Loma Linda. They got 6 casualties. They also had a lockdown. They had also a crisis in that at the nearby state mental hospital, there was a report of a shooting. What happened? They had to shut and lock down the hospital again. This impacted ambulances coming in. The police stopped every ambulance to inspect the vehicles and the occupants before they were allowed to roll up to the ambulance bay. That delays their care, but it's a necessary evil. So their after-action report said that their primary issues were security and safety, communication, and crowd control. The ED was crowded with non-essential personnel, and it was difficult to figure out at first who could help and who was in the way. And they felt that their triage was good, and I concur. From both hospitals, it's really clear that early notification permits staff to implement the mass casualty plan, to clean out the ED, empty out the hospital as best possible, prepare for incoming casualties, call in additional staff, and secure the hospital for safety. Now I'd like to take you back cross country. Now we're going to go to Florida. And here was another shooting, now it's over a year ago. Here we had a terrorist who murdered 49 people and wounded 53 others at a nightclub. The main hospital involved here was the Orlando Regional Medical Center, major hospital. It's a level 1 trauma center, and it was fully staffed. It was the middle of the night on a Saturday, and it was quiet. They didn't get any notification. This was the biggest failing. While the shooting was carrying on and the police were trying to shoot back, police and EMS were extracting casualties, taking them to a casualty collection point, and then loading them into vehicles and just driving straight to the hospital without letting the hospital know what was coming in. And that was unfortunate. That was perhaps the biggest failing. So when victims arrived, The hospital crew had no idea what to expect. They had no information. There was no ready net advance notice. The first patient arrived just after 2 a.m. Multiple gunshot wounds to the abdomen, awake and talking. But before that patient could be prepped for the OR, additional patients came in. A PD pickup truck dropped off a bunch of patients, again without notice, and 3 more casualties had to be addressed. Within minutes, all 6 trauma bays were completely packed. Before they had any idea of how many casualties might be coming, or if they could even make a wild guess, they were doing intubations, chest tubes, and thoracotomies in the ED. There were already multiple dead in this first wave, people who could not be saved at all. And immediately upon its heels came a second wave, and patients now began to fill the hallways of the emergency department. At this point, they initiated the mass casualty incident response. At 2 a.m, the clerks frantically tried to reach staff. People had their phones off, people were dead asleep, they had trouble reaching staff and bringing them into the hospital. Here, critical care and a hospitalist were invaluable. They helped dispo patients in the ED and admit patients as quickly as possible. 1 hour into the incident, the hospital incident command system was initiated and activated. 1 hour. Also about 1 hour into the incident, a code silver was called in triage. There was a report of a shooter in triage. Now, triage, right next to the ED, that's pretty darn close and scary. They barricaded the doors with the portable x-ray machines, so no one could come in from triage. All they had was the ambulance bay as the only ingress or egress if needed. And it turned out to be a false alarm. But you see again, safety becomes an issue. They noted that patient tracking was very difficult. They gave armbands. They noticed quite quickly that the electronic medical system they had was not up to the task. It could not capture the data fast enough or reliably enough. They went back to paper. But a lot of the paper got bloodied or wet. So they had a conflict in that in the patient documentation. They also had traffic problems with the constant flow from the ED to the ICU to the CT to the OR. There was a big traffic jam, essentially. Another wave of patients came in, and one of the doctors started doing CPR on a pulseless patient. And that's just not done in a mass casualty incident. Unfortunately, that doctor did not know the principles of mass casualty response. Now, once the patients were stabilized and resources demobilized, then the hospital was flooded, absolutely flooded by hundreds of family members looking for their relatives. If you remember back to that graph I showed you of the demands upon the system versus the time, this is when they started to come in, when people were starting to wind down. And suddenly they were inundated by people. And were these people sick, injured, or just looking for relatives? There's a lot of grayness in a mass casualty response, a lot of uncertainty. Their after-action report, they felt that they did a good job. They had done a lot of practice. They did tabletop drills, they did practical drills, they did drills with the community, and they did a lot of them. And they practiced regularly. But my question is, was their medical response really good? They did ED procedures. Perhaps they should have been better off done in the OR. The staff, not all of them, understood the principles of a mass casualty incident. How do you respond? They had a very late activation of the command center. But the biggest failure was communication, not on the hospital's back. It's not their fault. EMS and the police failed them in not communicating. We're coming in, there's been a shooting, expect 20, 50, 100, 200 patients. They should have done that. Now, I'd like to just discuss the military briefly. Unfortunately, because I don't have DoD permission, I cannot show all my slides. But I want to close the loop because mass casualty incident is best understood by the military. The military has the greatest experience with it, not just from war, but also from humanitarian assistance and disaster relief. And of all the branches, the Navy has the most experience. The Navy has ships offshore that are constantly ready to respond to tsunamis, war, and part of the Navy is the Marine Corps. So they have quite a bit of experience. I'm still in the service, and I may have another opportunity to practice this mass casualty response. I'm the medical officer for Marine Corps Infantry Unit, and things are getting a little uncomfortable in Asia right now. So who knows what might be. I would like to tell you that when I was deployed in 2006, 2007, I was involved in 7 mass casualty incidents. The largest had 44 casualties from a mortar attack. The experience we had was tremendous. Everyone who was there, whether active duty or reservist, went back and took that knowledge, that corporate knowledge, and integrated it into their practices in the military and in the civilian world. The triage and medical system in Iraq and Afghanistan led to the lowest death rates of the military history ever in the US. This was due to repeated practice and refinement. And the experiences have been absorbed by the civilian community. You can see how well San Bernardino did. Las Vegas did quite well as well. I have to tell you that the best lessons that were learned from the war, from Las Vegas, from San Bernardino, from Orlando, were 1, practice, practice, practice. 2, communicate. 3, stay semper gumby, which means always flexible. Thank you very much.
Thank you. Thank you, Dr. Spiro. Thank you. Any questions, comments?
Thank you again. That was fascinating. Very,
pleasure.
very fascinating.
Okay. All right. Thank you. Okay, we are going to now move on. Can I have a motion for the consideration of the minutes for December 13th, 18th, and 19th?
So moved, Mr. President.
Second.
Okay,
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Thank you, thank you. We're now going to take oral communications. Any oral communications tonight?
There are not.
There are none? Okay. Dr. Tsoi, thank you. Written communications.
Thank you. I'm going to present the confidential action items. Under appointments, we have 3 new physicians. We have Lisa Arcilla, pediatric cardiology, Cesar Java Hirian, emergency medicine, and Shiva Rajayi, internal medicine. Temporary privileges approved while applications waiting include Daniel Kennedy, critical care intensivist, and Shiva Rajayi, internal medicine. 2-year reappointments include Dr. Addie Jane, cardiology, Dr. Peter Lenny, nephrology, Dr. Rohit Sehgal, cardiology, Dr. Shirley Tsai, pediatric hospitalist, Dr. Albert Wang, internal medicine, and Dr. Jacqueline Wei, orthopedics. 1-year reappointments include Dr. Zulfi Ali, Dr. Ramin Begi, Dr. Padmavathy Kuduravali, and Dr. Jeffrey Thomas. There are no conditional or non-reappointments deemed to have been resigned. Transfer staff category include Dr. Shrong Chang, dermatology, provisional to active, and Dr. Lin Ning, emergency medicine, provisional to active. Completion of proctoring and advancement in staff category includes Dr. Shrong Chang, dermatology, Dr. Lin Ning, emergency medicine, Dr. Lakshmi Nair, cardiology, Dr. Naveen Bhatti, emergency medicine, Dr. Yi Huang, internal medicine. Completion of proctoring prior to eligibility for advancement in staff category includes Dr. Ajit Chikkabalapur. Extension of proctorship and provisional category include Dr. Kissing Si and Dr. Young Kang, both of urology. New privilege requests include podiatrist Sarah Karamlu and Dr. Sanaz Kayan, both for assisted surgery. Deleting privilege requests include Stephanie Carnes, PA, Dr. Addie Jane, cardiology, Dr. Huey Fan, pediatrics, Dr. Rohit Sehgal, cardiology, and Dr. Ra Sankavalli of urology. Withdrawal of applications include David Galaducci, emergency medicine. Request to return from leave of absence includes Dr. Eric Cohen, OBGYN hospitalist. Resignations include PA Chelsea Joshi, and Dr. Carol Kawada. That's the end of my report.
Okay, thank you, Dr. Soy. May I have a motion for approval of the credentialing action items?
So moved, Mr. President.
Second.
Thank you. D, please.
Director Wallace,
Aye?
Director Stewart,
Aye.
Director Eben,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Okay, thank you. Hello, Debbie.
Hi, good evening,
Good
everyone. So first of all, I'd like to thank everyone for supporting our gift shop this last month. We had a fantastic month. Look at Nancy over there, I love it. She was quite surprised.
It's incredible.
Thank you.
Record-breaking.
Thank you. I just want to thank the staff, the visitors, the families, all of those who support the gift shop, because it just was, I got goosebumps and I got definitely emotional when I saw the numbers. And I just can't thank you enough. It really means a lot. It means a lot to the Service League, because in turn, that means we're able to give to the hospital more, and that gift once a year. The other thing is, and we have a sale going on, so, stop by. And next month, we will start an inventory reduction sale as well, just because inventory is the end of the month, and I don't want to count all that stuff. Or neither do the other volunteers. So support is greatly appreciated. Now we're getting ready for our annual meeting next month, which is going to be February the 13th. And so invitations have gone out to all of you. I hope you receive it within the next day or so. We'll have our new board coming in, and I really feel strongly that the new board coming in is going to be outstanding. I'll still be on, but I'll get to be parliamentarian. So, but I think it's just new blood, and that's really important to keep things fresh and going and developing. We didn't have any information orientation sessions this last month in recruiting in December because of the holidays. It makes it a little challenging. But we did have an orientation session last week. So we had approximately about 25 new volunteers. We will have an information session on the 12th of January. And let's see, that pretty much covers it for that. But now volunteering hours, we're a little bit up for December because a lot of the kids and the students basically were all off of school. So adult volunteer numbers were 1,418. College, 396. High school was 456. Spiritual care, 58. Trainees, 47, giving us a total of 22,375. And I can't thank the volunteers enough, because bottom line is that the volunteers are so important. And with the new building being open very soon, and that transition, that excitement that's going on, we want our volunteers to realize that they are a very important part of this transition as well. Right, Nancy?
We spoke about that today.
Yes, we did.
We have a tall task ahead of us.
Yes.
And the Service League will be by our side the whole way.
Yep.
We are so fortunate. Thank
Yeah.
you.
Yes, I know I will, and I know the board will. So we just need to get all the volunteers on board, and let's do this and make it an outstanding time and growth for the Service League as well as for the hospital.
It's exciting. We have lots of work to do together.
I know. I am truly excited. So thank you very much. That pretty much covers it.
Okay, thank you, Debbie. Okay, Dr. Soy, back to you.
For the medical staff report, I'd like to report that we have 579 members, of which 337 are active.
Okay, hospital
We'll
calendar.
begin with the video, please.
Past health promotions and outreach events. In support of One Child, an East Bay agency for children, on Tuesday, December 12th, the Washington Hospital management staff donated hundreds of gifts, including bicycles, clothing, and toys to Tri-City area families in need. The families were identified through One Child and East Bay Agency for Children. Founded by Bernie Dutra, One Child is a nonprofit organization dedicated to providing underserved children with new clothing, school supplies, and holiday gifts. Mrs. Dutra's passion to provide all children with the basic necessities for success in school has allowed one child to serve over 5,000 children to date. East Bay Agency for Children manages the Healthy Start program for Fremont and Newark Unified School Districts. Upcoming health promotions and community outreach events. On Thursday, January 18th from 7 to 8:30 p.m., Dr. Victoria Leapart, gynecologist, will kick off the 2018 series of Women Empowering Women. Dr. Leapart will provide a 30-minute lecture followed by a 1-hour open discussion regarding women's issues. Topics of discussion may include goal setting, prioritizing your life, stress management, reclaiming self-confidence, and more. To register, call 510-608-1301. On Thursday, February 1st, from 3:30 to 6 p.m., the Washington Sports Medicine Program will host sports physicals at Newark Memorial High School. High school athletes from all sports in the Fremont, Newark, and Union City area are welcome. The cost is $20. All proceeds will be donated back to the schools for their sports medicine programs. On Thursday, February 1st, from 6 to 8 p.m., as part of the Diabetes Matters series, Vida Reed, RN, will present Diabetes 101. The Washington Township Medical Foundation will host 2 community open house events on February 1st at the Newark Clinic and on February 7th at the Nakamura Clinic in Union City. Both events are from 6 to 8 p.m. Community members are invited to visit the healthcare facility conveniently located in their neighborhoods. On Thursday, February 8th, from 6:30 to 8 p.m., Washington Hospital will launch the 2018 Mental Health Education Series. Mental health is an area that merits increased education and information regarding available resources. This 8-part comprehensive series will feature expert speakers on various areas of mental health. Participants are not required to attend every class. Topics include February 8th, Crisis Intervention, presented by Mark Rahman, Senior Family Advocate, retired, Family Education and Resource Center. A crisis situation may occur at any time when loved ones are no longer safe to themselves or others. Through this presentation, learn to recognize the warning signs of a crisis and understand what actions can be taken. February 22nd, Understanding Anxiety Disorders, presented by Dr. Seema Sehgal. This seminar will provide an overview of anxiety disorders, including panic disorders, generalized anxiety disorder, social anxiety, obsessive-compulsive disorder, OCD, and various types of post-traumatic stress disorder, PTSD. March 8th, Understanding Mood Disorders, presented by Dr. Seema Sehgal. This seminar will provide an overview of mood disorders, including major depression, dysthymia, and bipolar disorder. March 22nd, Understanding Psychotic Disorders, presented by Dr. Seema Sehgal. This seminar will provide an overview of psychotic disorders, including schizophrenia, schizoaffective disorders, delusional disorders, and depression with psychotic features. April 5th, The Link Between Substance Abuse and Mental Health Disorders, presented by Carmen Masori, PhD, UCSF. Learn more about how mental health disorders are common amongst a population suffering from substance abuse, including prescription and non-prescription drug addiction. April 19th, When Depression Occurs with Other Medical Conditions, presented by Simone Madan, PhD, UCSF. Depression can also arise in conjunction with other medical conditions or as a consequence of those conditions. Through this seminar, learn to recognize the signs of depression and when additional actions should be taken. May 3rd, Mental Wellness, presented by Michelle Williams-Smith, Senior Family Advocate, Family Education and Resource Center, and Dr. Victoria Leapart. Learn strategies to develop a wellness recovery action plan and explore the benefits of complementary therapies for the treatment of depression and anxiety. May 17th, Family Support, Caring for Those with Mental Health Disorders, presented by Michelle Williams-Smith, Senior Family Advocate, Family Education and Resource Center. Family members can be an invaluable resource for individuals dealing with serious mental illnesses. However, caring for someone with mental health problems brings unique challenges. On Tuesday, February 13th, from 10 a.m. to noon, as part of the 2018 Stroke Education Series, Melissa Reyes will present Stroke Prevention. The goal of this two-part series is to educate community members about prevention, symptoms, and what to do if you are experiencing signs of a stroke. On Tuesday, February 20th, from 10 a.m. to noon, Melissa Reyes will present Life After Stroke. This presentation provides an overview to better understand your condition and how to move forward after a stroke. On Wednesday, February 20th, from 1 to 3 p.m., Dr. Catherine Dow, cardiologist, will present Women's Heart Health. Dr. Dow will discuss the critical signs of heart disease and heart attack that females can experience. The Washington Hospital Healthcare Foundation report. Washington Hospital Healthcare Foundation received 2 community gifts in December. Students in the Leos Club of James Logan High School and students from Mission Valley Elementary School created handmade holiday cards for hospital inpatients. These cards were delivered to patients by the food and nutrition staff. On December 28th, President of Woolly Warmth, Maithri Ambudapati, delivered a large collection of hand-knitted items for pediatric patients to Aditha Aninau, nurse manager of Maternal Child Health. Woolly Warmth is a group of volunteers who provide handmade knitted and crocheted warm clothing to the families of newborns to keep their little ones warm and comfortable. The trustees of the foundation thank all of these groups for contributing gifts that benefit the patients of Washington Hospital. The foundation will host the 33rd annual golf tournament at Castlewood Country Club on Thursday, May 3, 2018. Held in memory of longtime Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. To reserve your foursome or sponsor the event, please call Washington Hospital Healthcare Foundation at 510-791-3428. Washington Hospital Employee Association, WIA. The Red Cross has issued an urgent appeal for blood donations. The extreme weather across the nation has resulted in cancellations of numerous blood drives. In response to this need, on Tuesday, January 30th, the Washington Hospital Employee Association, WIA, will sponsor a blood drive from noon to 6 p.m. in Anderson Auditorium. Community members are encouraged to donate. Registration can be completed in advance at www.redcrossblood.org and use code WHHS. Washington on Wheels WOW Mobile Health Clinic. During the month of December, the Washington on Wheels Mobile Health Clinic WOW continued to serve community members in the North Bay impacted by the October wildfires. Damage to the Santa Rosa Community Health Vista Clinic created a need for our mobile clinic. Internet and social media marketing. Washington Hospital's website remains very active. The hospital's About WHHS section was December's most viewed web page, with 31,707 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the total number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of December, Washington Hospital's cable channel 78 InHealth captured a Diabetes Matters program called How to Talk to Your Doctor. In addition, InHealth aired the December Board of Directors meeting and the following programs: updated treatments for knee pain, getting through the holidays when you are grieving, learn the signs and symptoms of sepsis, vitamins and supplements, how useful are they, and a presentation on the National Hospital Rating System for quality and patient safety. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
And now it's my pleasure to present our Employee of the Month for January. Her name is Jennifer Nunez Horner. She is a CNA and works in Central Transport. I don't think we've had many who are quite this special. This is quite a story, I'm going to tell you. And I'm very proud of this. Not many people convert a high school opportunity into a rewarding career, but Jennifer did. In 2002, she was in a high school independent study program that allowed students to shadow various healthcare workers at Washington Hospital. The commitment was for 450 hours, and she enjoyed 445 of them. She said, the first day I wasn't so sure. At 16 years of age, she wasn't sure if working in a hospital was the right fit for her. She said, all I had heard was the negative aspect of the blood and guts part. She laughs. That quickly changed, and Jennifer soon believed that patient care was the right path for her. At the end of the program, her enthusiasm and skills made Alice Santos, who's well known to this board and to our community, our former Assistant Chief Nursing Officer, say to Jennifer, when you get your degree, come and see us again. And she did, and since then has been excelling in patient transport. She enjoys being part of the transport team. She describes it as the blood flow of the hospital, and as a result, she's worked with patients and coworkers throughout the hospital. She believes in our patient-first ethic 100%. She says, I'm committed to treating patients like I would want my own family members to be treated. No matter what the circumstances, being here as a patient is an uncomfortable experience, and we need to make that experience a little better, a little smoother. Working in patient transport, she sees approximately 30 patients a day and tries to leave each one a little more comfortable when she arrives. Catherine Robinson, manager of the Central Transport and Lift team, is often impressed when seeing Jennifer transporting patients. She is always polite, professional, and compassionate. What pleases me most is that her career in healthcare is continuing to grow. She's currently a student at Ohlone College. She's soon to earn her Associate of Arts degree. She then will apply to the nursing school and pursue a bachelor's degree from a local university. This is a young lady with a plan. Her busy life also includes her husband, James, and their soon-to-be 4-year-old, Madison. All in all, I stay pretty busy, Jennifer says with a smile. Yet she makes time to raise money for the Unravel Pediatric Cancer Program, which is a nonprofit organization that has touched her heart. Once you hear from mothers who have lost children to cancer, you have to get involved. That's a direct quote. Last March, Jennifer co-chaired an annual fundraiser which raised $81,000 for this organization. I couldn't be more proud to have her as an employee. She's totally remarkable. Her positive demeanor, her commitment to patients, her desire to continue her education should result in a wonderful career for her here at Washington Hospital. And I, for one, am very proud that she's our employee. She's absolutely remarkable.
Thank you, Nancy. Okay, we're going to move to the Lean Kaizen report. Kimberly?
Good evening. Tonight I'm pleased to present another certified employee, but to begin with, just want to give you a little bit of information. As you know, in October of 2014, we started our Lean journey, which is helping us to become that high-quality, low-cost provider that we want to focus on going forward. And it's important that we have a number of employees and physicians that become certified in the Lean methodology and be able to lead Kaizen activities as we go down this journey. As you can see, the Lean certification training is a process that takes over a year, 12 to 18 months to complete, and it requires proficiency in the Lean concepts and the tools, because then we ask those who are certified to help lead us in different Kaizen workshops and to continue for us to roll this out throughout the healthcare system. There are many requirements that a person has to fulfill in order to be certified. As you can see, it includes not only 8 days of classroom training and education, but then it's also participation in Kaizen workshops and actually leading workshops. So tonight, I'm very happy to present, and maybe we can have Mr. Wallace and Nancy come forward. We have one person, is the latest person to be certified, and that is John Lee from Information Technology, IT. And at this point, we have 29 managers and 2 physicians who have been certified.
Come on, John, stand between us. John, thank you.
Thank you very much.
Absolutely appreciate what you've done.
Thank you, John.
Okay. Is Ed around?
Yes. There was an Ed sighting earlier. He is here.
Oh, and 16.
Thank you for that introduction, Mr. Wallace.
Somebody should
Okay.
explain that.
So, this month we have not a lot of new news on the schedule front. It's still moving along. You can see, as we've had the last several months, the last items to be completed are the connecting corridors. That's what's change order 67 and 133, and those are the things that will be the last things that will be finished up on this. The rest of the progress in the building continues to be good, as we'll see right here. So we've shown you this picture multiple times from different directions, but this is the PBX area that is in the basement. And this is one of there's actually space here for a lounge and a restroom and various other things, so it's I think a significant improvement over what they have. And yes, there is a window that floods that area with light. This is a nurse station in ED. You can start to see some of the finishes going into that nurse's station. Again, very bright space. This is the waiting area of the emergency department, getting sort of final touches. That white separator is separator between the pediatric area and the rest of the waiting area. Now this is a little dizzying, but this is the atrium as now with the scaffolding coming down. And you may note, the other thing you can pick up in this picture is this is all the structure on 2 levels where glass is coming down between the floors. So the 3rd floor and the 2nd floor is totally surrounded by glass, basically protecting the railings and everything else on that section. So clear see-through glass. The other things that are, when you do get to go through, you'll notice the section here that comes around and covers a part of the atrium. That's for the wand door, and the wand door is the fire protection. So when the fire alarm goes off, a door comes in and covers the entire atrium on the 2nd and 3rd floor, separating that space for fire so that fire cannot go up the center of the atrium. Okay. This gives you a look. We've seen several of these as we go up, as they go up the floors. This is on the 2nd floor. The restrooms, the public restrooms are getting completed. This is not the area that is the outdoor seating area, but it is another terrace on the front of the building facing the hospital, and you can see this is all going to be planted. There's several large planters throughout the terraces. Here you can see the progress in the restrooms on the 3rd floor. Again, other areas in the third floor are getting completed, doctor's charting room. And this is a section, I'll just take a minute on this. This is the very front of the emergency department. So this is going on right now and started before the rain started. But this is all an area that's been excavated. They're putting in the rebar, and this is going to be the structural supports for the canopy that will be in front of that building. So this whole section is covered first for walk-in traffic, and then also for the ambulances to pull in underneath and unload at the emergency department. So yes, they fall in line to cover this entry. So everything, anybody pulling in this section will be covered between the canopy and then the walkway into the building. Okay. And this just shows you the back. This is 67, which is the loading dock / back entry, back corridor that is a patient and staff corridor between the two buildings. And then you can just see that they're starting to put the footings in place for that as well. That's located behind the existing loading dock. This is a existing deionized water system, and that had to be moved out of the way for the back corridor. And you also notice we had a whole section, it's not that remarkable, but we had a whole section back there that was all different various years of asphalt. That whole section was varying angles, and runoff of water was interesting. So that's all been poured, and it's got one concrete slab. It's cleaned that all up considerably. So that's where we are in the construction. So continuing to go forward. Budget is okay. We're getting tighter and tighter every time I come and talk to you, in terms of change orders getting completed and negotiated out. And at this point, we're still to the good in terms of contingency of about $2 million. Okay.
Thank you. Dr. Stewart wanted me to explain the 0 and 16 comment that I made. For those of you that don't know, it's a rabid Cleveland Browns fan. Thank you, Ed. Thank you.
Oh, boy.
But his judgment on construction is tremendous. Okay. Mary.
We have Mary Borough.
Yes.
Good evening. Tonight I wanted to talk a little bit about our infection prevention program plan for 2018 and some focus areas we'll be looking into and policy and procedure updates and changes. But I think right now, first and foremost on everybody's minds is influenza. I mean, I think we've all been hearing a lot about it in the media right now, and the hospital has seen a pretty big influx since about the end of December. That also applied across the nation. About the last week of December, just increased sharply across the United States. As you can see on this bottom image here, all the red is actually considered high activity levels. So that's pretty overwhelming for the United States right now. The predominant strain that we're seeing, of course, influenza is a virus, and so it's the influenza A, otherwise known as H3N2. We're seeing quite a bit of that. And with that has come a lot of discussion about how effective is this vaccine. You're hearing numbers all over the media saying from anywhere from 10 to 30 to 40%. And I think what's important to remember about the vaccine is that while there are multiple strains that they try to put in it to prevent and make them be effective on immunization for patients, there's one that they are predicting based off of some Australian data that's about 10% effective. However, other strains such as the influenza A, H3N2, we're seeing closer to what we're thinking is closer to overall about 30 to 43% effective. The other one that we've seen quite a bit of here in the last couple of weeks is influenza B. And this is, I got an estimated effectiveness of about 73%. So I think the key message that I wanted to explain is that while we hear a lot about the vaccine being effective, in general, it's still a great idea to get it. It's not too late to get it, and it still warrants some availability on giving us some protection. Right now, the amount of people specific to California, the deaths are much higher than they were this time, even last year. You can see it's 27 people under the age of 65. And with influenza, you always think, okay, so of course we know the biggest risk groups are people over 65 and the very young and the very old. But to even see 27 under the age of 65 is pretty alarming at this point. And so that's why we want to really focus here at the hospital on taking steps towards preventing the spread of influenza. Alameda County Public Health Department for the last couple years has put into place a mandatory vaccine policy. So basically, if you're a healthcare worker in Alameda County, you are mandated to either get the vaccine or wear a mask while at work during flu season. So we've been able to increase our number of healthcare workers that are receiving the immunization drastically in the last couple seasons and including this season. By the end of April, we'll report out an overall number of influenza vaccines that we were able to give our healthcare workers because we provide them throughout flu season. We do blitz around and try and make it as easy as possible for the staff to get a vaccine, including medical staff also here on campus. Hand hygiene compliance will continue to be our first and foremost focus for preventing the spread of influenza, because that's one of the key components, obviously, that you can do to prevent yourself from getting the flu. And the Alameda County Public Health Department has recommended moderating our visitation policy. So kind of tightening it up to make sure that people that you're screening at the front don't have influenza symptoms and obviously don't want the very young here. In fact, the guideline that we're using right now is children below 16. There are certain units on OB with siblings where you can allow for some leeway in there. But for the most part, we're really screening carefully on who could come up and visit. It's not just about protecting even the patients and the staff. It's also when these people are coming, we don't want them to be exposed to influenza. And taking that a step further for the community, it's important to remind everybody things that they can do to prevent themselves from getting the flu. Again, like I mentioned, making sure you get your flu vaccine. Hand hygiene. I mean, it's interesting when you look at studies to see how often people touch their face during the day. And, you know, we're all touching all these devices now, and then you touch your face, and that's probably one of the biggest risk factors. And multiple times a day you do that. So if we're washing our hands appropriately, there's less risk of us taking it and spreading it to your nose or your mouth and therefore getting the flu. Cleaning and disinfecting surface and objects areas around you is another key. We've been working closely with the unit clerks to make sure that they're cleaning their areas in between shift changes. Our mobile machines that we use to walk around with the Epic machines, we've been cleaning the keyboards on those more frequently, making sure that we really keep the environment clean. When we have hospital orientation, we emphasize this with anybody in hospital orientation. It doesn't matter if you're on the front line or if you're a healthcare worker. Wherever you work in the hospital, you have a responsibility to disinfect and keep your area clean, so to protect yourself again and your families and the people you work with. So we'll continue to focus on that. And this applies to, like I said, even people in the community. Disinfecting can be a big weapon against this. The other thing is reminding people that when you do have the flu, it's important to stay home and limit your contact and not go out for sort of unnecessary trips. It's better to stay home, actually rest, get your fluids, relax, and let that virus run its course. It will shorten the course more likely if you sleep and rest at home, and of course prevent the spread to others in the community. Obviously, people have to leave home sometimes, and we encourage the community to wear a face mask to prevent the spread of it, because most of it is coming from a droplet, a sneeze, or a cough. So the mask really is effective at preventing that. And this flu season, I've actually been surprised about how many people I've seen out in public wearing masks, a little bit more than typical. Even this morning when I was walking across the hospital, I was noticing a couple people wearing masks. So I think that message is getting out. But now moving deeper into our program, some background on where our program came from. Infection prevention really started with the fact that the CDC started noticing about over 10 to 15 years ago that hospital-associated infections were on the rise, and there's a very, very big risk. About the time was 1.7 million Americans in the year getting hospital-associated infections. And it ended up being identified as one of the top causes of death in the United States. So the program really is always going to be focused on trying to bring those numbers down, trying to prevent patients that as they arrive here, we don't want to make them sicker, and so we need to put in multiple mechanisms that can prevent them from getting hospital-associated infections while they're here. The backbone of how we run the program really comes from the Washington Hospital Infection Prevention Committee. It is a committee that was established in 2006. And we actually, at the same time, about 3 years later, started submitting data on a national level to the CDC. So we've had some well-established structures in place for a while that have enabled us to keep good connections with presenting and collecting our data through a national database of NHSN and reporting it out. We've been doing that for many years now. Our program focus for this year is really taking our steps on how we're available for the staff, everybody, medical staff, EVS, anybody, on being a resource for them so that they have availability to contact us, not just Monday through Friday, 8 to 5. You'll find that that tends to be the standard in a lot of infection control programs, but on the weekends, people need the same sort of resources, and especially on night shift and on Saturday and Sunday, because a lot of these things tend to increase around that time period. So we've been able to add some weekend coverage to offer the staff more support. This has really been effective, especially in the ED. We have somebody present on campus now 7 days a week, and we always, of course, are available by phone to help and support, especially the health supervisor, anybody who may have questions. Continuing to do surveillance is another big focus, and catching and identifying hospital-associated infections as quickly as possible through a lot of the great software that we've been able to get by using EPIC and infection control modules that are specific to what we're looking for in the hospital. Dr. Diane Martin is a huge help to this program. I just can't emphasize enough. She really has a great vision for this committee and the program. She's incredibly committed to it. She's really been able to get us the right resources that we need and kind of give us the direction on where we need to head. She's very supportive to multi-disciplines across, and she always communicates on outside national groups also to make sure that we're staying current from her medical staff standpoint and opinions. I obviously have a role in the program. I have oversight to infection prevention program, but there are people below me who really do the work. The infection prevention program coordinator. We have, as I said, the weekend coverage, and we have a new role that we added last year, which is a dedicated staff member who goes every day and educates family members on to kind of help them say, when you're admitted to the hospital and there's a sign on your door and everybody's walking in and they're wearing all this PPE gear, this personal protective gear, it's kind of scary for family members, and it's hard to make them not feel like so isolated and outsiders. So it's really worked well for us in the last year, having this role of having her go into the room, teach them again, this is why you're on isolation. These are some things you can do at home. You may not be on isolation the entire time you're here. It's kind of an extra support mechanism that we found to be very satisfying for family members. Again, the program's key components are first and foremost focusing on quality and patient safety. That's what we want to do, to keep the patients safe while they're in-house by making sure that we put up the best protective mechanisms we can to stop the spread of infection. We do daily surveillance to make sure and that patients are not acquiring infections, and if we see any signs or symptoms of those, we can intervene as soon as possible. And part of that comes from really keeping the staff and patients educated. That's continuous. You have to do it. We're always going to have to educate about hand hygiene. We're always going to have to educate about devices and that are in a patient, like a urinary catheter or whatever, and make sure that everybody understands that when it's no longer needed, it should come out. We have protocols for that. These sort of focus areas that can really help us implement our evidence-based protocols. Another part of the program that I think has really helped us stay current with our policy and procedure is working with outside consulting services. And we've had about 3 really active relationships with outside consultants, one of which is the Stephen Hurst and Associate Group. They're a consulting firm that we've worked with since about 2009. They've sent in staff and consultants in their group that have worked very closely with the infection prevention program members, providing education, support, and making sure that we are following outside national recommendations and meeting those standards. Another thing that we have done with the increase of C. diff in 2014, when we started to recognize that this was a problem that we wanted to address very aggressively, we sent out a request to the CDC and asked if they had any consulting services that they could offer even on a state level, and they were able to set us up with a epidemiologist, and she came out here, looked at all the data, and made recommendations that really became the foundation for what we've done to prevent C. diff over the last couple of years. And lastly, we have a day-to-day relationship almost with the California Department of Public Health, working closely with them on their hospital-associated prevention program. This is a program that the state of California has made available to all hospitals. I think because they're associated with CDPH, people start to think, well, you're inviting a regulatory group in and just letting them look when you don't have to, but bring them into your hospital. And it is voluntary, and we've decided to do that. We've done it actually a couple times over the last couple years, shown them our C. diff data, said, if you have any recommendations, let us know. And they've looked and validated our data collection. We've had good results with that, 80 to 90% matching with what they found. And they've toured the facility and made recommendations that have been very helpful to us. We are required to report out to quite a few groups, actually. Like I mentioned before, the CDC, we report to them through our National Healthcare Safety Network database. Obviously, CMS has made this a very strong focus, hospital-associated infections, especially since the initiation of the Affordable Care Act. We have to provide them data on central line infections. We have to provide them data on C. diff, surgical site infections. They look at about 6 components that they can even reduce your payment on, depending on where your data is looking at with that. So it's a very key part of keeping a relationship with CMS and making sure that we're reporting to them appropriately. And I mentioned our role with CDPH. And our local Alameda County Public Health Department, this is a day-to-day relationship we have with them. We have high TB population here, and so we're constantly calling them, working with them, making sure that we're managing these patients appropriately and that they're safe to go home when they're ready. We do have some additional updates that I think will impact our program in 2018. Joint Commission, as of January 1st, stated that whenever they're going out further to do their accreditation surveys, any surveyor that observes any member, healthcare worker, physician, anything, not doing hand hygiene will immediately be cited on the spot. Whereas on the survey that we just finished, they look for trends, and they would give you feedback and say, oh, we saw this particular person not wash their hands as they walked in, and it was sort of this discussion. And if they found a heavy trend, then you were cited. And now they have been announced that one witnessed non-hand hygiene compliance from them will be an automatic citation requiring an action plan. So clearly, to me, that sends a big message that hand hygiene is a big focus for them. So we'll be working further to make sure that we have a robust hand hygiene program and that we continue to focus on making that something that we're looking at for our observations and with employees. The Centers for Disease Control updates their plans in their manuals every year. They sent it out for January 2018. There's not a lot of significant changes that will impact us this year. Most of what they want us to report mandatory now, we've been reporting voluntary since 2009. So that didn't lead to a lot of changes, and they'll update their calculations moving forward. Another requirement that we follow up on is the annual risk assessment. So once a year, the infection prevention team has to sit down and look at all the data that we had in the last year and say, what do we think is going to be the biggest risk we're facing in the next year? So Dr. Diane Martin, myself, and the team met in December, looked at all the data, and came up with some focus areas. And basically, we will continue to focus on how we prescribe antibiotics and to make sure that they're appropriately prescribed to the right patients for the right period of time. And that will be led by the antimicrobial stewardship team. Again, hand hygiene compliance, and C. diff, because C. diff continues to be a challenge for us. So we'll continue to have that be a focus. So those were sort of the lessons and guidance we got out of doing our risk assessment. And the other thing is, after having all of these surveys this summer, we really wanted to say, what did we learn from them? What were some conversations and things that we had from them? Even though we came out really on the successful end of those with very limited citations, there were still things that when we spent so much time with them that we were able to get some feedback from them about, what are some things that we could do and focus on improving. And one of which is the use of airborne isolation rooms. We're going to continue to focus and make sure we're monitoring those correctly. These are patients who are on TB isolation, a very strict isolation. We need to continue to monitor that closely. and making sure that we are working very close with environmental services, that if we learn something new about disinfecting and cleaning a room, we need to be sharing that with EVS right away. And we've added our infection prevention team members and to go and meet with EVS on a monthly to quarterly basis and go over teaching about room turnover and how to clean it, make sure that those are cleaned appropriately. That's a big part of how you can prevent the spread of hospital-associated infections. EVS works incredibly hard to do this for us, and I always think that they're a group that sometimes we overlook as seeing the importance and impact, and they're a huge part in patient safety for us, and they've been doing a great job for us, especially in the last month with what we've been seeing with the influx of influenza patients. Dialysis is another unit, high-risk population. These patients tend to be at risk for getting hospital-associated infections. We want to focus a little bit more on what we're doing to prevent infections there. So those will be our focus areas, in addition to, of course, moving into the Morris Hyman Critical Care Pavilion. I think for us in the program, of course, this is going to be a big area of improvement for us. Just the mere fact that we're going to have so many more private rooms. They've got the easiest floors and counters to clean, the technology for monitoring airborne isolation patients. We're going to see some huge benefits from this, and we're very excited to see that opening, and as I think it will help us moving forward. We'll continue to surveillance a lot of what I've already mentioned, but patients in ICU who are on ventilators, patients who are at risk for getting blood infections, surgical site infections, these things will be a huge part of our surveillance. And I mentioned earlier about the opening and how much of the building and how much it's going to help us, but there'll be a lot of construction going on from now to the opening of the building that's going to require a lot of infection control assessments to be done to make sure that while this construction is going on, we're protecting our employees and any patients or anybody who could be around in the area. So that'll be a big focus for us also. Water management has been a new focus from the CDC that they've asked us to actually add into our plan and look at closely. Infection prevention works very closely with engineering and Robert Alvari, and he's been a great help to us in making sure that we're meeting the standards on making sure that our water has got correct temperature monitoring. Are we testing it for pathogens that do well and thrive in the water but are deadly if they get into certain areas? And so we want to make sure that we're really looking at water management and testing. And so we're going to continue to meet on that to make sure that our protocols and policies are up to date. That'll be something a little different than what we've done in the prior years. And another thing that will be much easier in the new facility to manage. And use of disinfectants and making sure that we have the education out to staff and everybody on how we're using our disinfectants. Products change throughout the year. Vendors come out with new, better products that are easier and less caustic on the environment and more effective. So we have to make sure that we're keeping up a relationship with vendors and products committee to look at, are we always using the best product to disinfect? So we'll continue to focus on that. And as I mentioned, antimicrobial stewardship. We've made some changes there with the program that pharmacy has basically been involved in. We've added a dedicated pharmacist to make sure that that person can be looking at the antibiotics to make sure that they're prescribed appropriately and completed appropriately. Dr. Martin co-chairs this with the other pharmacists, and they are looking at this monthly and reporting this out to the committee. I think that will help. TB in this area is something that we will have to continue to focus on very strongly this year. We've actually seen a slight increase on that, and the employees that we have working here have a lot of support from employee health on coming in and making sure that we are testing them every year to make sure they haven't had any exposures and aren't showing any signs of having TB themselves. And again, working with the medical staff to make sure we identify patients coming in with suspect TB and we isolate them appropriately and give them the treatment that they need to be safe to go back home. A recent example that I have with TB surveillance comes out of the ED. This was actually at the end of December. We had a patient who presented in the ED with symptoms of TB, temperature, cough, and came into registration. And actually, the registration clerk was able to identify this as a risk for some sort of airborne type of risk she recognized quickly. She said, okay, so let's get the mask on the patient. Right after the time she registered him to identify it was about 3 minutes, and this patient was masked within 5 minutes. And as a result of that, we didn't have any exposures that we had to chase back because the patient did in fact end up having TB. So a suspect, and to have a patient identified within 8 minutes and masked of walking into your ED is really a great success story. Typically what happens is in a lot of these circumstances, the symptoms are a little harder to identify and they get identified further down the road, and then you have to worry about, have you exposed the staff? So we had a great deal of success by that. And I think it's because infection prevention has been spending a lot of time with ED and huddles and working with registration and everybody. And we've seen a lot of improvement in how we're masking people. It's a great safety mechanism. I think you've all heard about the influx of CRE, carbapenem-resistant enterobacterales, that we're seeing. This is a really resistant bug, has a high mortality rate, over 50%, something we have to take very seriously this year. I think if you were to ask Dr. Martin one of her biggest concerns right now with bugs, she would probably say this one. We're cleaning all areas with bleach when we see these patients. We've seen a lot more in California in the last year, and we saw about 6 of them here in 2017, or 6 admissions. One of the patients was admitted twice. You have to change your staffing ratio even, and make sure that you limit the people who go in the room, and do terminal cleans with bleach every single day in that room. This is a scary bug, and we need to take it very seriously this year, identifying it quickly, managing it appropriately. And I think antimicrobial stewardship has done a great job on that so far. And again, making sure that the room is clean daily has been something we've been able to do. It's all bleach. Very similar to C. diff. C. diff is something that we have seen a slight decrease in last quarter, which I'm happy to report. And next month I'll be bringing that data forward to you. But it's not something that we can sort of take our focus off yet, because it's consistently sort of in the Bay Area, gone up and down in many hospitals. And so we will have to continue to have the state come in, make recommendations, work with reviewing our data, seeing what we can do to help to prevent the spread of it further. We've enlarged even our isolation signs, made the bleach available in more areas, and we'll continue to do that over this year. One of the things that comes up quite a bit when our educator meets with staff is a lot of patients say, well, what am I going to do when I go home? You have grandparents living with grandkids now, and they start to get scared about, we don't want these things to spread. So I think it's worth some time to provide the community some education on what they can do to prevent it when they get home. And the key is really to wash your hands with soap and water for at least 20 seconds, getting a lot of friction. Soap and water will really help get the C. diff off of the areas. And cleaning their areas and bathrooms, we're encouraging them to even use bleach at home, changing your linens on a regular basis. And if patients come home with the prescription with C. diff, it's very important that they take the entire prescription, just as you would say with any prescription, but especially with C. diff, to avoid it getting further resistance. And patient education that we have done in this new role has focused on really that, preventing these multiple drug-resistant organisms from spreading, and working with the community outreach. Dr. Martin has done a couple public service announcements over the last years. We found that to be very effective. She'll probably be doing and asking to do some more of those this year. It's great. It gets out to a large part of the community. And staff education, we will also continue, making sure that, especially new hire employees, that they get their education that they need, and that we have actually provided a website from infection control that the staff can go on, especially health supervisors. It's nice for them to be able to review the programs and to have a resource to look at on night shift, to go pull policy if you need to, things like that. That website really needs to be up and current. So we have really been focusing on, so what will we do in the future to make sure our program continues to stay robust? And it's really following a lot of direction that comes from the CDC and Medicare. That's where we get a lot of our initiatives from. We'll continue to do that. Making rounds. You have to have infection prevention present on site in front of the staff, having access to them, and making sure that they're there as a resource. We will continue to focus on. And almost every year there's an outbreak that's unsuspected, and we need to be prepared for it. And we have been sort of going around some of our policies on outbreaks and surge management. And in fact, the presentation we saw this evening, infection control, needs to have an active role in that. And I think that's a great resource for us that I'll be bringing back to the committee, because there's definitely a key role for infection prevention in those sort of incidences.
Thank you, Mary.
Thank you.
Any questions, comments?
Thanks.
Great presentation. Thank you,
Thank
Mary.
you.
Okay, Chris.
Okay, tonight we'll be looking at Washington Hospital's operating and financial results for November. We'll move right into our operating indicators. The average daily census for the month came in at 157.8, just a little bit less than the budget of 158.3. We had 1,022 admissions against a budget of 954, but our patient days were 15 below budget at 4,735. That all adds up to a lower length of stay. The average length of stay for the month was 0.61 below budget at 4.37. We'd expected 4.98. Our outpatient observation equivalent days for November were 85 below budget at 122. And again, I think that has a lot to do with a lot better management of our observation patients. Moving into utilization, case mix index for the month was a bit lower than budget at 1.488. We had 148 deliveries, just 2 below the budget for the month, and that's up from what we've seen the past several months. Surgical cases were 15 below budget at 362. That includes our joint replacement cases that were 19 above the budget at 146. Our neurosurgical cases were just 2 below budget at 23. Our cardiac surgical cases were 1 above budget at 11, so really the difference there coming from general surgery area. Cath lab procedures for the month were 26 below the budget at 285. We'd expected 311 for November. Our outpatient visits for the month were 178 above the budget at 7,228. We really saw that in the lab and cardiac rehab. We're really seeing the volume in cardiac rehab increase over the last couple months, so we'll keep watching that. Our emergency room visits for the month were below budget by 241 at 4,031. Quick look at cath lab activity for November. Cardiac activity really won the prize for the largest share of the activity. Peripheral vascular was 35%, followed by non-vascular interventional radiology and neuroradiology. Looking at productivity, productive FTEs for the month were 34 above budget at 1,293.4. We had 161 non-productive FTEs in November, giving us total FTEs of 1,454.4. We'd expected 1,421.9. Our FTEs per AOB came in higher than expected at 7.06. We had budgeted for 6.52. So, we get down in some of these slow months and it gets a little difficult to flex down, although folks were really trying. Moving into the financials, first we'll look at our Governmental Accounting Standards Board presentation. This is the presentation we're required to use for our audited financials. Total patient revenue for the month came in actually $1,087,000 over budget at $166,295,000. Our contractuals in November continued along the vein that we've seen the last several months. Lower than expected at 75.73. So we end the month with net operating revenue just a little over $1.9 million above the budget at $40,851,000. Operating expenses for the month came in a bit over $1.5 million above the budget at $39,362,000. Several drivers there. One was our higher FTEs, pushed our salaries and wages up. We continue to see high health and welfare claims in our benefits. I think I mentioned this last month, but just to remind you, over the last several years, we haven't hit our stop loss levels, which is, for those who aren't familiar with what that is, we're self-insured, and stop-loss insurance is a reinsurance against really high claims. We didn't hit our aggregate level for that last year until May. We hit our aggregate level for stop-loss this year in October. So again, really high claims. We'll see what happens the rest of the year. Our purchase services and pro fees were above budget by about $217,000 in the month. That really being driven by our contract dialysis service. As we've mentioned before, we're working on bringing that service in-house. We had hoped to have it done in October. Now it looks like by the end of February we'll have that done. That service is not unbudgeted. It's a bucket issue. It's really budgeted in the form of salaries and wages because we expected to have it in-house at this point. So it skews that line item, but really it's incorporated in other parts of the budget. The other item of note is our provision for bad debt and charity. We continue to see higher private pay patients. So our provision for bad debt and charity was about $428,000 above the budget. So we ended November with an operating bottom line, actually pretty good performance, $382,000 above the budget at just under $1.5 million. Non-operating income for the month was about $500,000 below budget at $1,206, and largely driven by that unrealized loss in our investment of $498,000. So we end November with a total bottom line about $162,000 below the budget at $2,695,000. So any questions on November's performance? Okay.
Okay, we're going to talk about our preliminary results for December. Our gross revenue amounted to $174.7 million and came in below budget by $1.6 million. It was below December a year ago by about $180,000. The inpatient gross revenue was $2.1 million above budget. The outpatient gross revenue was $3.7 million below budget. The major drivers of revenue were surgical volume, which was below budget by 5.6%, and that's predominantly general surgery. Driving surgical services revenue, $2.3 million below budget. Observation days were below budget by 32.8%, and that drove the room and board revenue below budget by $670,000. This is not an altogether bad number. In fact, it's a good number because basically in the observation days we're providing general acute care level of care for a greatly reduced rate paid to us by the federal government, and there's no way that we cover the costs. This is evidence of the good work of sound physicians as our hospitalists, getting these patients discharged on a timely basis, and it is actually beneficial. In its own discrete category, it looks like it's not a good number. Overall, it's an outstanding number. The birthing center saw a lower C-section volume. C-sections were down by 38.3%, and that drove the birthing center revenue below budget by $424,000. Our inpatient cath lab procedures came in above budget by 28 cases, and this drove the cath lab revenue above budget by $1 million. Although the total inpatient days are below budget by 116, the ICU days were above budget by 18.3%, 106 days. That drove ancillary services revenue above budget by $1 million. So again, patient mix kind of offsets some of the issues with volume. In terms of our key census statistics, our average length of stay was 4.68. We came in below a budget of 4.96. The average length of stay was 0.09% below December a year ago. Outpatient observation days were 61 below budget at 125 days. Outpatient observation days were 89 below December a year ago. Our average daily census of 168.5 was below a budget that called for 172.3. A year ago, at this time, the average daily census was 2.8%. Our current budget was 2.8% below December a year ago. Admission trends. They're slightly below budget at 1,067. That's 0.8% of the variance. Patient days of 5,225 are below budget by 116. Compared to December a year ago, they're 86 fewer. Surgical cases we've talked about already, but we'll mention again. In December, we were 353 cases below budget. We had a total of 353 cases. We're below budget by 21. Compared to a year ago, we're 15 fewer. Inpatient surgeries were 1 below budget at 274. Outpatient surgeries were 20 below budget at 79. Neurosurgical cases came in above budget by 9. Cardiac surgeries were above budget by 1. General surgical cases were below budget by 9. Joint replacement surgeries were below budget by 22. It's a 15.8% variance, and below last year's volume by 12. I think that joint replacement being a highly elective procedure, that as the holidays approach, people are not interested in having their knees and hips replaced. Cath lab procedures for December were 336, 3 cases above budget, and 9 more than we had December a year ago. Inpatient cath lab procedures of 193 were also above budget by 28. Outpatient cath lab procedures were below budget by 25. Peripheral vascular procedures in the cath lab were above budget by 18. Non-vascular interventional radiology procedures were above budget by 8. Neurointerventional radiology procedures were the same as we had budgeted. They came in at 11. Cardiac procedures were below budget by 23 and below last year's volume by 13 cases. Deliveries for December of 155 came in above budget by 8. That's a 5.4% positive variance. And they were 9 more than we had December a year ago. And as I mentioned earlier, the C-sections were below budget by 23. Non-emergency outpatient visits of 6,877 were above budget by 227. That's a 3.4% positive variance. And these visits were also above December a year ago. The lab visits were above budget by about 312. That's a 13.4% positive variance. OB visits were above budget by 121. Cardiac rehab visits were above budget by 83. X-ray visits were below budget by 139. Short stay visits were 104 visits below budget at 159. Prenatal diagnostic center visits were 41 below budget at 117. But you know that we're now open in our clinic, finally. Miracles never cease. The women of Washington Township, I'm sure, are a great deal happier. The emergency department visits of 4,568 were 6 below budget. That's pretty spot on. And below the same period a year ago by 93. Our productivity indicators are as follows. The FTEs were below budget by 94 at 1,196.3. That's a 7.3% variance. Non-productive FTEs were above budget by 26. That's an 11.2% variance. Total FTEs of 1,454 were below budget by 68. Total FTEs per adjusted occupied bed came in at 6.59, and that's on budget. Washington Outpatient Surgery Center had 461 cases in December, 38 cases fewer than they had budgeted. The clinic visits of 3,803 were below budget by 116 visits. That's a 3% negative variance for the month. And there were also 99 fewer than December a year ago. Washington Urgent Care was 51 visits below budget. The Nakamura Clinic was 66 above budget. The Newark Clinic was 126 below budget. Warm Springs was 17 below budget. The Ohlone Clinic was above budget by 12 visits. The preliminary payer mix for the month of December is as follows. The government-sponsored patient revenue made up 69.5% of total gross revenue, which came in below the budget of 72%. The HMO revenue was 3.8% of gross revenue, which came in above budget, which called for 3%. The PPO revenue was 23.8% of gross revenue, which was also above budget. The budget had called for 23.2%. Private pay revenue was 2.9% of gross revenue. We had budgeted 1.8%, and this is a direct reflection of the timber by timber destruction of the Affordable Care Act and the exchanges. And I expect that number to continue to grow. Days cash on hand for December ended at 172 days. It was down 19 days from the last month. However, we made a pension payment funding of $22.3 million this past month. And we remain, compared to virtually all the other employers that we know about, one of the few employers that are responsibly funding their employees' pensions. Something we should be proud of. The days of gross revenue and accounts receivable were 58, which is a very good number. There were $905,812 in charity care applications pending or approved in December.
Okay, any questions? Thank you, Nancy. Thank you, Chris. Okay, we're going to move on to the action items this evening. Item A, which is a consideration of the 15-month extension for previously granted temporary construction easement.
Mr. President, in accordance with district law, policies, and procedures, I hereby move that the board authorize the chief executive officer to execute a right-of-way agreement, including the grant of a temporary construction easement for the period November 1st, 2017 through January 31st, 2019, between the district and the city of Fremont, in a form substantially described in this memorandum to the Board of Directors. In addition, the Chief Executive Officer is authorized to take any and all further actions which, in the determination of the Chief Executive Officer, are necessary to accomplish the foregoing.
Second.
Okay, we have a second. Comments?
I'd just like to explain that this is an easement that was previously granted by the board. The location is Civic Center Drive and 2500 through 2780 Maury Avenue. And the construction easements are for 8,429 square feet.
Thank you. Dee, please.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Okay, item B.
Item B is the PACS upgrade. Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to approve the appropriate contracts to purchase hardware and implementation services in the amount not to exceed $214,860.
Second.
Okay, Dee, we have a second. Comment.
You want me to please explain?
I'm sorry. I'm sorry.
This is
I thought it was-
the Hospital Picture Archiving and Communication Systems. That's what PACS stands for. and it's critical for storage and access to all of our patient imaging data. And this is an upgrade that is important to maintain appropriate security levels and stay current with the latest software releases. And this is a planned upgrade to the system.
Okay, thank you, Nancy. Go ahead, Dee.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
All right, item C.
This is the MediStim MiraQ system. Mr. President, in accordance with the district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the purchase of the MediStim MiraQ Ultimate Patency Verification System with imaging for a total amount not to exceed $175,000.
Second.
Okay, we have a second, Nancy, please.
Our two cardiac surgeons, Dr. Beggy and Dr. Lee, have requested the purchase of this piece of equipment. I'm not going to repeat its full name. The equipment allows the surgeon to evaluate and analyze the graft flow measurements during open heart surgery to avoid conduit failure. And that is what would result in a return to surgery due to a leaking or ineffective graft. It allows them to test it in the OR. It's a major improvement in patient safety. Strongly recommend it.
Thank you. Dee?
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, item D.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts to proceed with the purchase of the Philips Healthcare software and network upgrade and patient link replacement for a total amount not to exceed $190,000.
Thank you.
Second.
Nancy?
Okay, this is a piece of equipment which ties the physiological monitors together and also with Epic in the OR, the recovery room, the cath lab, and the OB area, OR. And this started as a project to ensure that our monitoring system would link to the system going into the Morris Hyman Critical Care Pavilion. As it turns out, these upgrades were critical because Philips is discontinuing support for the current network. So it's a must.
It's a must.
And it
yes.
was budgeted.
Yes. Thank you. Dee?
Director
Aye.
Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, item E.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to approve the appropriate contracts for the purchase of the Hill-Rom Allen table in an amount not to exceed $112,192.58.
Thank you.
Second.
This is an item that was requested by Drs. Kunwar, Eichbaum, Erasmus, and Hensdorf. They requested last year that we take a look at a new table, and there's been an intensive evaluation of several tables for the last 6 months. The tables were brought to the operating room for use on cases so that all surgeons could experience the comparative utility of these tables. After extensive review, the surgeons have unanimously chosen the Hill-Rom Allen table as their new table. The cost of the table was included in our capital asset budget.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, item F.
It's just interesting to see how complex these surgeries are based on the cost of the table. Sorry to interrupt.
Oh, good. That's okay. Item F.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board adopt Resolution 1184, which will provide a construction budget amendment of the pipe project for the kitchen for an amount not to exceed $1.3 million, and to authorize the chief executive officer to complete all appropriate contractual documents to complete this project.
Second.
Nancy?
The name of this is unforeseen conditions. It's very hard to know what's under the floor of a building that's been sitting there since the late 60s. Back in November of 2016, the board approved a resolution. It was number 1175, and you gave us a budget of $1,962,000 to replace the pipes under the kitchen in part of the original building of Washington Hospital. The pipe replacement project's been underway since July, and since starting the work, a number of issues have been uncovered. Contaminated soil appeared around the pipes being replaced. An extra rat slab and moisture barrier had to be demolished to get into the pipes. Corroded electrical conduit was discovered. Mold was discovered in the walls and floors of the kitchen, and we had to increase the size of the lift station to meet the regulatory requirements that currently exist. All these conditions were required to be ameliorated by the state of California. Due to the additional scope of the work that has been discovered during this project, we have also had to extend the lease of our kitchen to go, temporary kitchen at the back of the hospital. The total of the additional scope and extended overhead conditions comes to $1.3 million. And unfortunately, we're dealing with the replacement of an underground sewer pipe where you cannot get a good look at the existing conditions until you start the project.
Okay, well, thank you. Lee?
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Thank you. Item G.
This has to do with the reappointment to the Washington Township Hospital Development Corporation. Mr. President, in accordance with district law, policies, and procedures, I move that the board reappoint Ben Saw, M.D., Russ Blowers, Miro Garcia, Gloria Vilsana Furness, and Jeannie Yee to the Washington Township Hospital Development Corporation for the 2018 calendar year.
Second.
These are all really good people.
Yes.
This is something the board is required to do annually. The Development Corporation Board of Directors serve at the pleasure of the district board.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Okay, well, thank you all. At this point, we're going to adjourn to a closed session. Okay, we're going to reconvene the open session and announce that no reportable actions were taken during the closed session. Seeing that there is no other business, this meeting is adjourned. Good night.